Good evening.
Good evening, sir.
Well, today we're going to discuss surgical bleeding and hemostasis, also blood transfusion. I hope you can see my presentation about surgical bleeding.
Yes.
All right. Well, let's get started. Blood is the unique fluid because it can get hard, it can make clots, and this prevents the blood loss. It is the coagulation, the function of the blood. So blood circulation is essential, and for delivery of the nutrients, oxygen, and removal of the wastes of the metabolism, it's necessary to pump the blood through tissues. So blood must be liquid. But in case of bleeding, in case of damage of the vascular bed, the animal or human can lose the blood, and the blood loss will lead to the death. That's why it is a very interesting property of the blood to form clots. This process needs regulation because if clots appear inside the blood vessel, it would be disaster. Blood clots will occlude the vessel and stop circulation. That's why blood clots must appear generally only in cases of the vascular wall damage. This is the function of the coagulation, and coagulation is a very complex mechanism which has several stages and regulatory mechanisms which are linked between processes. The byproducts or result products of the cascade activate or deactivate the previous stages of the coagulation. This is self-regulation. First stage of the blood coagulation is vascular constriction. After the damage of the vascular bed, the injured epithelium releases substances. This is endothelin, also bradykinin, and fibrinopeptides, which are vasoconstrictors and constrict the smooth muscles of the vessel, thus decreasing the blood flow through the damaged area and facilitate hemostasis. Also, platelets, which are circulating in the blood, release biologically active substances. It is serotonin, arachidonic acid, which is activated as thromboxane A1, which also constricts the smooth muscle and facilitates hemostasis. So blood vessel constriction is the first stage of the hemostasis, but it works only in small arterioles and capillaries. But if large caliber vessel is damaged, then vascular constriction is not strong enough to stop bleeding. That's why another mechanism is also activated. It is so-called primary hemostasis. Primary hemostasis leads to the platelet clot formation, primary clot or platelet clot. Um, when um, the wall of the vessel is damaged, the
Doctor, excuse me, can we see the presentation?
We can see the presentation. It's probably only you who can't see it, but we can.
yes, I think
I can see it. I can see
Yeah,
the
I can see.
presentation.
No, I can
So
see
you
it.
need to check. I can.
I'm sharing the presentation at the moment. So maybe it's the problem on your side, on your computer or browser. You can restart your browser, close and reopen. Maybe it helps. So after the damage of the endothelium, which envelopes the blood vessel, the basement membrane is exposed to the blood. And this area contains von Willebrand's factor, the substance which initiates the platelet plaque formation. It activates platelets and they attach with each other with fibrin bands. Such clot is initial stage of the fibrin clot formation. So it is the initial clot and it initiates process which will lead to the definite clot formation. That's why it is called primary clot. Heparin does not interface with the activation of platelets. That's why patients with hypocoagulation caused by heparin still can form platelet clots. So small bleeding possibly stops during the heparin overdose or high concentration of the heparin in bloodstream. And in case of von Willebrand's disease, when von Willebrand's factor is absent or abnormal, this stage of coagulation is affected or does not occur. And as a result, the next stages of the coagulation is also are affected. Calcium is important. Calcium is very important component of this aggregatory process, and also other substances which are released during the insult. This could be epinephrine or other catecholamines also activate the platelets and participate in first initial plaque formation. So several processes occur during the platelet activation. It is the cascade of the processes which lead from the arachidonic acid to the thromboxane 2 activation, and as a result, further vasoconstriction and thrombocyte aggregation. Aspirin and other non-steroid anti-inflammatory drugs block this process, because they interfere on cyclooxygenase enzyme, and that's why aspirin prevents the platelet plaque formation. It is not always bad. Usually, when there is a trauma, of course, or surgery, aspirin can lead to the bleeding. bleeding is more intensive than without aspirin usage. So in these situations, aspirin works quite bad, but its effect is negative. But during several diseases, for example, atherosclerosis, when atheromas or deposits of the cholesterol in the blood vessels are opened. So first, during atherosclerosis, the cholesterol is deposited in the vascular wall under the intima, so under the endothelium. But late, endothelium is removed, and the atheromatic deposits of the cholesterol are exposed to the bloodstream. And these areas, in these areas, von Willebrand's factor is activated, and the platelets can aggregate. The platelets can attach to the areas of the atheroma during atherosclerosis. And aggregates of the platelets can occlude the blood vessel. This is the common reason for myocardial infarction or acute coronary syndrome during the atherosclerotic coronary disease. In this case, aspirin works quite well. It suppresses the primary clot formation, thrombocyte aggregation, and it really extends the life of the patients. And there are trials comparing coronary artery stenting and aspirin usage. So in case of survival from the coronary artery disease, the aspirin has better results than stenting of the coronary arteries. Of course, stenting removes all symptoms. So patient which has coronary artery disease and suffers from this disease cannot move. Every physical activity can increase the demand of the oxygen in myocardium and cause pain. And after the stenting, patients return to the usual work and physical activity. It is excellent. But in case of survival, usage of the aspirin has better results than stenting. And after the stenting, the usage of the aspirin is common practice, because stents placed in the narrow area of the coronary artery can get occluded with the primary clot, platelet plaque. And aspirin prevents such clot formation very well. Another way is activation of the prostacyclin, which leads to the vasodilation and inhibits the platelet aggregation. So these limbs of the activity of arachidonic acid is are opposite. So look at it. It is vasoconstriction and thrombocyte aggregation, and vasodilation and inhibition of thrombocyte aggregation. So first, vasoconstriction, this limb is activated. So vasoconstriction, and platelet aggregation. And late activation of the prostacyclin down-regulates this process to avoid too much platelet aggregation. Um, so this stage of coagulation, platelet plug formation, is inhibited by aspirin and other non-steroid anti-inflammatory drugs. Also adenosine monophosphate and nitric oxide. How can we check this stage of coagulation? Is it normal or abnormal? So bleeding time is the test which can show this the activity of the second stage of hemostasis. Bleeding time is rarely used in everyday practice, but when there is a suspicion of the abnormality of the platelet plug formation, it can be prescribed, and it is a simple test when ear of the patient is pierced with a scarificator, and it starts to bleed, and the time is measured until bleeding spontaneously stops. Okay. The fibrinogen is an important component of the coagulation cascade, which attaches the platelets to each other together with the glycoprotein 2B and 3A. And they form, together with the von Willebrand factor, they cause like glue. They act as a glue, attaching the platelets to the vascular wall and also with each other. Third stage of the coagulation is actually the coagulation cascade. It is the activation or sequential activation of the coagulation factors, and the result of this process is conversion of the fibrinogen to the fibrin and formation of the fibrin plaque. So if primary plaque is a platelet plaque, the definite or secondary plaque is fibrin plaque. These are coagulation factors which participate in the coagulation, in this process. And also there are many other substances which influence on this process. All of the clotting factors except 8 are produced in liver. Imagine all the clotting factors except 8 are produced in the liver. Why is it important? During the liver diseases, the production of the coagulation factors is affected and the patient has hepatic coagulopathy. Factors 2, 7, 9, and 10 are vitamin K dependent clotting factors. So vitamin K is necessary for their synthesis in the liver. And this moment is used to control coagulation. So anticoagulation medications, warfarin, for example, blocks the K dependency, K vitamin absorption, and deficiency of the K vitamin leads to the decreased release of these factors and by liver and decreased coagulation state. And that's why K vitamin is antidote of the warfarin. If in case of overdose of the warfarin, parenteral administration of the vitamin K activates release of these factors from liver and corrects the deficient hemostasis. vitamin K is fat soluble. That's why during conditions when the patient is unable to absorb fat, vitamin K deficiency occurs. For example, during the biliary obstruction, there is no bile in the gut, but bile is necessary for emulgation of the fats. Otherwise, lipase will not active to destroy lipids or fat. That's why bile is necessary. Bile is essential for fat metabolism. And when there is no bile because of biliary tract obstruction, the patient quickly develops vitamin K deficiency. And also, usually, such patients with blocked biliary tree quickly develop biliary cirrhosis because of bile hypertension in the liver. And these two processes, biliary cirrhosis and vitamin K deficiency because of absence of the bile in GI tract, will lead to the hypocoagulation. Factor 7 has a shortest half-life compared to the other factors. This is the simplified diagram of the coagulation cascades, which I made for you. I think you will enjoy that. So there are intrinsic pathway and extrinsic pathway. Both activates the common pathway. And the result of the common pathway is fibrin clot, conversion of the fibrinogen to fibrin. So look at it. For intrinsic pathway, the stimulant is the damage of the vessel wall, while for extrinsic pathway, the initial trigger of this cascade is damaged tissue. Intrinsic pathway is slow process, while extrinsic is launched in seconds. To check the activity of the intrinsic pathway, we use APTT, activated partial thromboplastin time. And to check the activity of the extrinsic pathway, we use prothrombin time. So prothrombin time is checked with a special test, but these test results differ in every laboratory. Sometimes there is a normal range in the same, there are different normal ranges in the same laboratory. That's why in order to make results of the test and normal values, normal range equal, they use another kind of presentation of results, and this is INR. So INR, international normalized ratio, is the same for thrombin time test, but more universal. INR is the same PT. And the intrinsic pathway is suppressed by heparin, while extrinsic pathway is suppressed by warfarin. So heparin and warfarin are anticoagulation medications, and their mechanism differ. Heparin is called direct anticoagulant, while warfarin is called indirect anticoagulant because it works through the vitamin K blockage in the liver, and it blocks the release of vitamin K dependent coagulation factors. So damage of the vessel wall activates factor 12. Activated factor 12 activates factor 11, then 9, 8, And factor 8 activates common pathway. For the extrinsic pathway, tissue thromboplastin, which is in tissues, activates factor 7, which activates the same common pathway. So this is the combination of the factors 10, 5, and calcium, which activates factor 2, and it converts the fibrinogen to fibrin and creates the fibrin clot. This is the fibrin clot under the microscope. Maybe it is not through microscopic view, but a little corrected by artists. But anyway, it can show that fibrin clot is formed by the network of fibrin fibers. And components of the blood stuck inside. That's why this such clot can stop bleeding. You can see red blood cells, white blood cells, and platelets, which stuck inside this mesh made of fibrin fibers. Regulation of the coagulation. Actually, formation of the clots is dangerous process. Of course, it saves the life because clot obstructs the defect in the wall of vessel. It stops bleeding and stops blood loss. But if the coagulation is overactivated, then it can lead to the propagation of the clot beyond the site of injury. So not only the injured area will be occluded by the clot, but all the vessel and maybe more. This happens, for example, when the patient has necrotic fasciitis. Necrotic fasciitis is caused by infection by Staphylococcus and sometimes Streptococcus, and these microorganisms release enzymes which activate coagulation. They cause coagulation inside the blood vessels, and also infection is incorporated in these plaques. So these plaques are septic clots because besides fibrin and elements of the blood, inside are microorganisms. There is an infection inside. So these microorganisms release more enzymes and more coagulation occurs. That's why the coagulation is propagated through along the vessel. This leads to the cassation of the blood circulation and necrosis. This is the reason for such necrotic fasciitis.
Sorry, Doctor.
Yes.
Can I ask a question? Because you said this because you said the coagulation factor, facilitates necrosis. Yeah, which I agree. Do you say the intrinsic factor is the one that facilitates the necrosis, or the extrinsic factor facilitates the apoptosis? Is that correct?
Okay, no. Tissue factors don't participate in this process.
No, I'm talking about the reactive oxygen species. This cascade involved reactive oxygen species, which involve in the blood clotting formation. I'm talking about reactive oxygen species, not actually tissue factor itself. Because if reactive oxygen species can precipitate also what's called blood clot formation, which can lead to necrotic factors. So that's why I'm trying to think whether the extrinsic pathway or the extrinsic pathway is the one responsible for either apoptosis or with a necrotic factor because reactive oxygen species.
Okay, your question, as I understand, is about the this coagulation cascade, and you are interested in which coagulation factor is activated by microorganisms, isn't it?
Yes,
So,
yes, please.
to tell the truth, I have no answer about this on this question. I don't know exact mechanism of the activation of coagulation system, but I know the main principle that microorganisms, enzymes which are released by microorganisms activate this cascade, coagulation cascade. I don't know exactly which factor, but it leads to the overcoagulation. That's why if you inject the anticoagulants in this patient in small doses, it could be harmful and useful. Useful because they stop propagation of the thromb and more formation of more necrosis. But it could be harmful because it can stimulate circulation of the small clots in the systemic circulation, and spread of infection all over the body. It is bacteremia, first of all, then it is sepsis, generalized infection, and also metastatic purulent processes. So infection from this area, from area of the primary infection, propagates to another areas of the body, and metastatic abscesses can form in soft tissues, heart, eye, brain, lung, liver, etc. So anticoagulants anyway must be used carefully in this area. So main treatment, by the way, of the necrotic fasciitis is the debridement, wide incisions, removal of the non-viable tissues, and draining of the infection, and of course antibiotic treatment. Only antibiotic therapy is not will not lead to the successful results. Propagation of the clot beyond the site of injury is bad, and it can lead to serious consequences. Such regulation, down-regulation of the coagulation or prevention of the overcoagulation is mediated by two mechanisms. One is the feedback inhibition of the coagulation cascade. So next activated products of the coagulation cascade suppress previous factors, and this is feedback, negative feedback. And also activation of the fibrinolysis. Fibrinolysis is the mechanism which is opposite to coagulation. So coagulation is the formation of the blood clots, but fibrinolysis is destruction of the blood clots and makes clots liquid. So it's opposite process. Repair of the injured vessel with deposition of the connective tissue, and also vessel wall is covered with endothelium from inside, and this stops exposure of the von Willebrand factor. This is also a mechanism of down regulation of coagulation. Look at it. This is the feedback mechanism of the regulation. Factor 2 activates thrombomodulin. Thrombomodulin protein C, and protein C downregulates factors 9 and 8. The same is true for the antithrombin 3. So this is the negative feedback, which deactivates coagulation cascade and leads to the prevention of overcoagulation. Now, another mechanism, it is fibrinolysis. Actually, it is the last phase of the coagulation because clot which was formed during the coagulation process must be removed. It is abnormal. It was needed just to stop bleeding. But now when vascular bed healed and there is no defect, the clot is not needed anymore. So it must be destroyed. And we have such mechanism. It is fibrinolysis. It is activation of the plasminogen, which activates, which is converted to plasmin. Plasmin is a very potent proteolytic enzyme, and it leads to the destruction of the fibrin, and fibrin degradation products appear in the blood. So, in our body, there is an equilibrium of two processes. It is coagulation process and fibrinolytic process. That's why blood is liquid. When coagulation cascade is activated, then clots appear, but this process leads to the activation of the fibrinolysis and absorption, destruction of the clots. So there is an equilibrium. This is self-regulated, very complex mechanism. Now let's discuss several coagulation factor deficiencies. So most common deficiencies are factor 8 deficiency, factor 9 deficiency, and factor 11 deficiency. Factor 8 deficiency is hemophilia A, and also von Willebrand factor, because factor 8 and von Willebrand factor act together. And factor 9 deficiency leads to hemophilia B. Factor 11 deficiency to hemophilia C. So these four abnormalities are most common, but there are many abnormalities of the coagulation system. Coagulation and fibrinolysis mechanisms are essential for the normal functioning of the body. That's why deficiency of the coagulation factors have no consequences, clinical consequences, if they are above 5% of normal. Imagine the only deficiency of the coagulation factors the deficiency of the coagulation factors have clinical consequence when it is below 5%, so around 5%. If it is deficient, for example, if it is 20% of normal, it still has no symptoms. 10% of normal has still no symptoms. So if it is around 5%, then a patient have minor disease. It is minor bleeding after major trauma or surgery. If it is below 5%, from 1 to 5, then it is moderate disease. Then the patients bleed after the trauma, but in surgery, but such complications are still not so common that it will not result spontaneous bleeding. So in severe trauma or surgery is again necessary. But if the concentration of the coagulation factors are below 1% of normal, then it is severe disease. Such patients can bleed spontaneously. And bleeding occurs in joints, into the joints, muscle masses forming large hematomas, in the retroperitoneal space, bleeding from the gastrointestinal tract, upper GI bleeding, lower GI bleeding, genitourinary system, from the retropharyngeal bleeding, intracranial hemorrhage, bleeding from the tongue or lingual frenulum below the tongue. So it is very severe abnormality. Von Willebrand's disease is most common congenital bleeding disorder. It is autosomal dominant, and there is a low level of the von Willebrand factor and also factor 8. They both are important for platelet adhesion. That's why formation of the primary clot, platelet clot is affected. Symptoms are easy bruising, even after the insignificant trauma, mucosal bleeding, menorrhagia or too much blood during the menstruation. There are 3 types of this disease, and the treatment is does not exist. Treatment doesn't exist. Just compensation is possible with concentrate of the von Willebrand factors and factor 8. They are infused in case of severe hypocoagulation and bleeding. Also, desmopressin acetate is used to treat such patients, and type 3 disease is most severe. Usually, such patients are unresponsive to therapy. Factor 11 deficiency, it is called hemophilia C, autosomal recessive disease. It is it affects the Ashkenazi Jewish population. This group of Jewish population live in the Western Europe and United States, and usually such disease is mild or moderate. Severe cases are rare. Bleeding may occur after surgery, trauma, or any invasive procedure, and rarely spontaneously. The treatment also does not exist. Just fresh frozen plasma is transfused to compensate the factor 11 deficiency. Also, other factors sometimes are deficiency. That's why recombinant factor 3A and desmopressin acetate has good result, activate deficient coagulation. Other deficiencies like deficiency of the factor 2, 5, and 10 are rare and also treated with the transfusion of the fresh frozen plasma. Factor 8 deficiency is autosomal recessive, and bleeding after trauma or surgery is delayed. because of activation of the fibrinolysis system. Usually, babies after birth bleeds from the umbilical stump. Also, intracranial hemorrhage and spontaneous abortion because of the hemorrhage under the placenta is common. The compensation of the deficient 13 factor is possible with the transfusion of the fresh frozen plasma, cryoprecipitate, which is the same made of fresh frozen plasma, also concentrate of the factor 13. Inherited factor 7 deficiency is rare, and typical symptoms are easy bruising, epistaxis or nasal bleeding, oral mucosal bleeding, postoperative bleeding. Treatment again is fresh frozen plasma or recombinant factor 7A. You remember, I think, that factor 7 factor has most short half-life. That's why frequent infusions are necessary, and because of factor 7 is quickly deactivated. There are many abnormalities of the platelets. There are abnormalities of the quantity of the platelets, abnormality of the quality. Also, surface protein abnormalities and intrinsic defects of the platelet, and a lack of release of the biologically active substances. Surface protein abnormality is a rare autosomal recessive condition which is called Plasman thrombasthenia or Bernard-Soulier syndrome. Intrinsic platelet defect means that granules of the biologically active substances inside the platelets absent, or they lack biologically active substances. Dense granules are deficient. That's why the platelets cannot release active substances and cannot activate the coagulation cascade. That's why bleeding is variable. Delayed platelet syndrome, when alpha granules of the platelets are abnormal. Sometimes both dense and alpha granules are abnormal, and in this case it is severe abnormality which leads to the bleeding, and platelet transfusion is would be necessary. And there are many acquired platelet disorders. First of all, quantitative disorders, or disorders of the quantity of the platelets. Failure production or decreased survival. So you know that platelets, when get old, are removed from the bloodstream by spleen. So this process dysregulation of this process can lead to the coagulopathy. So failure production, it's the impaired bone marrow function, where you know that platelets are released by the bone marrow, and actually these are not the platelets are not cells, but small particles of the cells which are called megakaryocytes. So this process of generation of platelets are affected during the leukemia when lymphocytes proliferate in the blood, in the bone marrow, and suppress other cells, including megakaryocytes. Myeloproliferative disorders, vitamin B12 and folate deficiency, chemotherapy and radiation therapy also kill the proliferating cells, including the megakaryocytes. Intoxication, including the alcohol intoxication and viral infections. Now, increased destruction of the platelets. First of all, immune-mediated disorders. It is most common. Idiopathic thrombocytopenic purpura. Idiopathic thrombocytopenic purpura is the condition. I think, yes, I have the picture for this condition. Idiopathic thrombocytopenic purpura is autoimmune disease. So nobody yet knows the reason, but the immune system generates antibodies against patients' own platelets. And these antibodies match the platelets, and after that, such antigen-antibody complexes are detected by spleen, and such platelets with the antibodies on the surface are removed from the bloodstream and destroyed. That's why patients develop thrombocytopenia. The platelet count in blood gets low. This will cause the formation of bruisings in the skin. Tiny bruisings are called petechia. Sometimes it is called rash. It is not rash, but bruisings because of the low platelet count. It is possible to develop in adults or in children after the viral infection, which is trigger of the idiopathic thrombocytopenic purpura. The treatment for this condition is different. As a first-line treatment, corticosteroids, intravenous immunoglobulin, and anti-D immunoglobulin is used because of the autoimmune mechanism. This kind of therapy suppresses autoimmune attack against platelets. If this treatment fails, then second-line therapy is splenectomy. So spleen is the site of platelet removal and reason for the thrombocytopenia or low platelet count. That's why removal of the spleen improves the condition of the patient. This is actually no treatment, but platelet count becomes normal after the removal of the spleen. This operation is done with open approach if the spleen is too large, giant, or by laparoscopic approach. But I want to mention that about 40% of individuals have additional splenomegaly, small spleens adjacent to the main spleen. And surgeon must seek for these splenomegaly and remove all the spleens. Otherwise, if small additional spleen is left in the abdominal cavity, it will grow as a compensatory mechanism and will lead to the another attack of thrombocytopenia. And if this treatment also fails, and after splenectomy platelet count is not does not increase, then other treatment. It is a monoclonal antibody against the surface antigen of B cells. CD20 is the antigen. Rituximab is a monoclonal antibody is used. Also, other medications and thrombopoietic agents are used to increase the quality of platelets. Disseminated intravascular coagulation, I will discuss this problem later, but it also decreases the quantity of the platelets in the blood. Again, thrombocytopenic purpura and hemolytic uremic syndrome are disorders related to the platelet thrombi formation or destruction of thrombi. And abnormalities of sequestration of the platelets during portal hypertension, sarcoid tumor, lymphomas, and Gaucher syndrome, Gaucher disease, the platelets destroy because of sequestration. And qualitative disorders as massive transfusions, therapeutic administration of the medications which inhibit or suppress the platelets, and diseases like liver conditions, monoclonal gammopathies, and myeloproliferative disorders can lead to the affected coagulation because of abnormal platelet count. Heparin-induced thrombocytopenia. You must always remember about this complication of heparin therapy. So usually we use two kinds of heparin in our practice. One is the natural heparin, or it is also called unfractionated heparin, and low molecular weight heparin. This complication is typical for both kind of heparin, and it is rare. And heparin therapy causes thrombocytopenia, generation of the antibodies against the platelets. It is mentioned in some degree in 70% of cases of unfractionated heparin usage, and in 8% of low molecular weight heparin usage. The result of this complication is low platelet count. Platelet count is low enough to cause bleeding. Such patients die of bleeding. I observed such case in the United States during my training. They detected heparin-induced thrombocytopenia in time, treated the patient in ICU, used everything, included the thrombocyte concentrate, but unfortunately could not save the patient. It was severe case, and patient died with this complication. The diagnosis can be done with a special analysis, which is called serotonin release assay, and the ELISA test. And the treatment does not exist. Treatment does not exist. Just we must stop heparin usage and switch to another anticoagulant. alternative anticoagulant. Of course, when there is no platelets in the blood, we must use platelet concentrate. And 1 unit of platelet concentrate is made several packs of blood. And it increases the circulating platelet count by approximately 10,000. You know that average normal value is 200,000. But it is quite dangerous to use the platelet concentrate because it leads to the high concentration of the platelet in the bloodstream and formation of the clots in the vessels. That's why platelet concentrate must be used only when platelet deficiency caused bleeding. If there is an active bleeding, you can use platelet concentrate. Otherwise, it is quite dangerous. Now, DIC syndrome, disseminated intravascular coagulation syndrome. It is a severe the condition with high mortality, and the reason for mortality is actually bleeding. So it is overcoagulation, but the reason for death is bleeding. So different conditions can lead to the same effect, to the excessive thrombin generation inside the vessel. So we started our lecture today with information about the necessity of the coagulation system, that blood in the vessels must be liquid in order to deliver the nutrients, oxygen, and remove waste products. So circulation of the blood would be impossible in case of clots. So blood must be liquid. But in this syndrome, clots appear inside the vessel. What is the reason? Actually, there are many reasons. It could be the injuries of the central nervous system, fractures with damage of long bones with the bone marrow inside, embolization with the amniotic fluid, malignancy and activation of the coagulation cascade by malignancy because of high concentration of the tissue factor, organ injury, for example, severe pancreatitis, liver failure, vascular abnormalities, including dissecting aneurysm, snake bites, drugs, DIC syndrome is a complication of blood transfusion, as a complication of transplant rejection of the transplanted liver or kidney, and as a complication of the sepsis. So there are also many other reasons for development of the DIC syndrome. So usually they are local processes in one area of the body. They are not systemic processes, but local processes mainly. And these processes will lead to the activation of the coagulation cascade and formation of the thrombin inside the vessel. These thrombs appear in the blood vessels of affected organ or affected tissue. And such thrombosis consume the coagulation factors and platelets. They consume majority of coagulation factors which circulate in the bloodstream, and also platelets. So in other areas of the body, there is a deficiency of the platelets and coagulation factors. That's why diffuse bleeding starts in the areas far from the initial pathology. So this is DIC syndrome. So because of consumption coagulopathy, this is called consumption coagulopathy, because clotting factors and platelets are consumed in the area of DIC, and they are deficient in other areas of the body. So we can detect thrombocytopenia, low platelet count, elevated prothrombin time, fibrinogen is deficient, fibrin degradation products, D-dimer, soluble fibrin monomers are elevated. These are markers of the DIC syndrome. And what is the treatment? Of course, treatment is the treatment of the primary condition which caused DIC. But also we must compensate the deficient platelets and clotting factors, and best method is fresh frozen plasma. Frozen plasma. Also, low doses of the heparin prevents excessive thrombin generation in the blood vessels, inside the blood vessels, and improves the condition. So heparin, fresh frozen plasma, and treatment of the primary condition is the treatment of DIC syndrome. And I mentioned the coagulopathy of the liver disease. So you know that most coagulation factors are synthesized in liver. That's why liver conditions, liver diseases, diffuse damage of the liver parenchyma can lead to the high prothrombin time, or INR. Also, during the portal hypertension is this complication of liver cirrhosis. So many conditions of the liver lead to the same result. It is liver fibrosis. That means that stroma of the organ, connective tissue, is increased inside the liver, and actually this is the scarring process in liver parenchyma. Hepatocytes are deficient and they are replaced, they are destroyed by the primary disease which caused the fibrosis, and they are replaced with the connective tissue during liver fibrosis. And the end stage of liver fibrosis is cirrhosis. And during liver cirrhosis, the majority of the liver parenchyma is connective tissue. That's why blood from the portal vein cannot easily pass through the liver to the hepatic veins in inferior vena cava. The liver has high resistance to the blood flow. That's why blood pressure in the portal vein is increased. This is called portal hypertension. And you know that spleen is the component of the portal system, because splenic vein enters the portal vein. That's why if pressure increases in the portal vein, it will cause the increased blood pressure in the splenic vein and inside the spleen. So spleen now is congested. It is full of blood. It gradually grows and leads to the splenomegaly. So splenomegaly is just enlargement of the spleen. But unfortunately, in this case, splenomegaly also leads to the hypersplenism or increased function of the liver, of the spleen. So splenomegaly is only about the size, hypersplenism is about the function. So function of the spleen is increased, and as a result, increased destruction of the thrombocytes in the spleen occurs. And this will lead to hypothrombocytopenia, thrombocytopenia. And you can even judge about the liver cirrhosis, how advanced the liver damage is, about the degree of thrombocytopenia. It is so constant during the liver.
Doctor, I have one question.
Yeah.
If we have this spleen function low, for example, hyposplenism, can we use this method, this portal, to increase this portal this portal hypertension to use to treat? No, but to get like vice versa effect. For example, if we have a hyposplenism, use this method to get hypersplenism, and with this method to increase the function of the spleen.
No, liver cirrhosis is quite severe condition, and actually it killed the patients. Most common reason for liver cirrhosis in Georgia is viral hepatitis C. In the countries of the Eastern Asia and Southern Asia, most common reason for the liver fibrosis is and cirrhosis is the viral hepatitis B. Also, in some countries, there is a small amount of patients with liver cirrhosis caused by alcoholism, alcohol consumed. Only cure from the liver cirrhosis is liver transplantation. It is quite severe condition, and of course you cannot cause the portal hypertension to treat other conditions. But if you want just to stop draining of the splenic blood to the portal vein, you can just ligate it. Such treatment is possible, or even surgery is not necessary. Splenic vein can be occluded by intravascular technique without any incision. What is really necessary?
Okay, thanks.
Sorry to go to support.
Yes.
Sorry, just to add something. Can we do liver dialysis for this?
Dialysis?
Yes. Can you do dialysis for?
Okay, thank you. Thank you for your question. That's right, that during the kidney diseases, kidney failure, during the terminal kidney disease, which is quite similar with the cirrhosis, isn't it? So loss of the function of organ. And during the kidney failure, we use hemodialysis. There are several methods of hemodialysis, but it is another subject. So it's the equipment which filters the blood instead of kidney. Such treatment also possible for the liver. There is a artificial liver, the system which also removes the ammonium or main toxin which must remove liver actually. But this system mainly is used during the acute liver failure, not during the cirrhosis, but also possible to use during the cirrhosis if the patient is getting ready for liver transplantation. Such equipment, most famous equipment of this kind, is called MARS. And in Georgia, in Tbilisi, we have one such device in the high technology center, surgical center. But it is not so effective as kidney dialysis, and you cannot use the MARS in chronic patients. Of course, you know that the kidney dialysis is used for chronic patients, isn't it? They go to the center with this equipment at least twice a week, and they are connected to the dialysis machine, or maybe intraperitoneal dialysis equipment, and it is impossible for liver patients. First of all, it is very, very expensive, and not so effective as for kidney. And that's why it is used only during emergency. So when there is an acute liver failure, for example, when child swallowed too much acetaminophen and has liver failure. In this case, it is possible to connect the child to the MARS and wait until the liver restores its function. Liver has very good self-repair ability, self-restoration ability, but usually patients die until liver improves its function because of brain damage. Because detoxification function of the liver is most important. Liver removes ammonia, which comes from the colon. And ammonia is very toxic for the brain. It causes at first encephalopathy and then brain edema, and it has high mortality. Actually, it will kill the patient. Brain edema will kill the patient because it will cause the inclination of the medulla oblongata in the foramen magna, and also tentorium of the brain. So, and another cause of the death is bleeding, hepatic coagulopathy and bleeding. So hepatic coagulopathy is easy to correct with a fresh frozen plasma. But what about the encephalopathy and ammonia in the bloodstream? So it can be removed with the MARS. So in case of such emergency, of course, you can use artificial liver machine or MARS, but not for the chronic liver cirrhosis patients.
Thank you. Thank you.
You're welcome. Now treatment of the liver coagulopathy. It is fresh frozen plasma and vitamin K. Fresh frozen plasma contains coagulation factors, while vitamin K stimulates generation of the coagulation factors by liver itself. Of course, it is slow process, and vitamin K will not improve the coagulation abilities of the blood at once. It needs at least 7 to 10 days to take effect. That's why we just use fresh frozen plasma, which contains coagulation factors. Okay, platelet transfusions effect only for a short time because transfused platelets are quickly removed by the spleen. Splenectomy or splenic artery embolization with intravascular technique can improve the coagulopathy and count of platelet count. And also it is possible to decrease the portal pressure by TIPS, transjugular intrahepatic portosystemic shunt. Okay. I think I described already this sequence, which is here. Impaired bile production or blockage of the biliary vessels will lead to the um, absence of the fat absorption in the gut, because bile is necessary to emulgate fats. Otherwise, fat will not be absorbed. So there is no bile in the bowel. That's why no fat is absorbed. And vitamin K is fat-soluble vitamin. That's why it can be absorbed only together with the fat. That's why deficiency of the vitamin K and deficiency of the coagulation factors for which vitamin K is necessary occurs. Coagulopathy of trauma is also important point. In general, I mean major trauma, not small cuts or etc. It's crushing injury or multiple organ damage, maybe fractures and also internal organ damage together with the blood loss. So severe condition, major trauma leads to the release of the tissue thromboplastin, in high amount of tissue thromboplastin in the bloodstream. Also, acidosis, which accompany the trauma, and shock, hypothermia, exposure of the body to lower temperature, and dilution of the coagulation factors after the massive infusion are the reason. And shock itself, what is the shock? So we will discuss shock later. Shock is the vascular failure, is the condition when blood circulatory system fails. So it is vascular failure. And this will damage the tissues because of ischemia and activation of the anticoagulant and fibrinolytic pathways and hypocoagulation. So the result is the activation of the anticoagulant state, and also enhanced fibrinolysis, which can lead to the bleeding, usually from the areas which are far from the damaged areas. Now, a few words about the anticoagulation. There are two groups of anticoagulants. It is direct and indirect anticoagulants. Direct is heparin, and indirect is warfarin, which acts as through the blockage of the vitamin K in the liver. The dosage of the heparin can be adjusted with APTT, activated partial thromboplastin time, while dosage of the warfarin can be controlled with INR, which is the same prothrombin time. And it is possible to inject continuously heparin by pump or by other systems of delivery. I said that there are low molecular weight heparins. So for heparin, for unfractionated heparin, strict control is necessary to avoid overdosage. For low molecular weight heparin, such laboratory tested is not necessary, because its effect on the coagulation system is predictable by dose. But for unfractionated heparin, it is unpredictable and control is necessary. During the heparin overdose, it can be neutralized with antidote, and protamine sulfate is the antidote of heparin. So warfarin, as I already said, is vitamin K dependent coagulant and anticoagulant, and its antidote is vitamin K. Also, you can use fresh frozen plasma to compensate the deficiency of the coagulation factors caused by the warfarin. These are symptoms and laboratory data for the anticoagulant overdosage. It is hematuria, presence of the blood in urine. It can be macrohematuria when when the urine is red and the presence of the blood is obvious, or microhematuria when color of the urine is normal, but you can detect red blood cells, increase the count of red blood cells in urine. Soft tissue bleeding is possible, also intracerebral hemorrhage, skin necrosis, bleeding into the abdominal cavity or internal bleeding, intramural bowel hematoma formation, and rectus sheath hematomas. So insignificant physical activity will stretch the rectus abdominis muscle, and the tiny branch of the inferior epigastric artery can get damaged, and it will cause rectus sheath hematoma. Okay, and when surgery is possible, it is controlled by the APTT or INR. Of course, in coagulation panels, there are many other values, but I'm talking about the most useful and the most important values. And anticoagulation is very useful before or during the surgery to prevent activation of the coagulation factors and thromb formation. So to prevent deep vein thrombosis or thromboembolism, we use anticoagulation. But of course, it can increase the likelihood of intraoperative bleeding or postoperative bleeding. That's why.
Sorry, doctor.
Yes.
You say in the surgery, if you give heparin, so while in surgery, that can activate CYP that is a P450, and that can knock effect. Don't you think that can also knock effect by creating another hemorrhage? Because if you give that will activate CYP P450, and that can activate, complement, and which can also increase bleeding.
Yeah. Yes. Usage of the anticoagulants, including the low molecular weight heparin before surgery, increases the likelihood of the intraoperative bleeding and postoperative bleeding. But some patients have very high risk of embolism, thromboembolic complications. For example, it is the trauma patients. Also, oncological patients with malignancy. Also, when the surgical trauma is very large. For example, removal of the large mass from the retroperitoneal cavity, or colectomy, total colectomy, the surgery which removes all the colon, or pancreatic duodenal resection, such major surgery. Also, other factors can increase the likelihood of the thromboembolic complications, like age of the patient. When patient is elderly, the likelihood is high. Also, maybe some mild or severe coagulopathies. So now, I recently, not recently, but about 1 year ago, I had a patient with thrombophilia, the factor 5 and 8 abnormality, which leads to the hypercoagulation and thromb formation. So imagine the patient with several risk factors. For example, oncological patient, also elderly, and also massive surgery. So triple risk for embolism, for hypercoagulation. So in such patients, administration of the anticoagulant before surgery is very useful because you must estimate risks. The risk of bleeding against the risk of deep vein thrombosis or thromboembolism, pulmonary artery embolism. And if you are sure that surgical hemostasis during the surgery, your technique is perfect, and you can use some advanced devices which lead to the good coagulation with secure coagulation, like LigaSure device or argon beam coagulator, good equipment. Also, you can use you can stimulate coagulation topically. You can apply fibrin glue or just fibrin fibers on the surface of the liver, for example, or spleen. So in this case, the risk of bleeding is much lower than the risk of the embolism. And after such judgment, you can use the anticoagulation before surgery. But usually we use low molecular weight heparin after surgery, after 12 hours from the surgery, 12 hours of the surgery, when risk is average or low. Risk of thrombosis is average or low. But when risk is high, of course, you use during or prior to surgery. Now, excuse me, local hemostasis. You are at the site of the traffic accident or other kind of trauma, and patient bleeds from the large artery. It is arterial bleeding. You know, the pressure in the artery is high, and the patient can lose large amount of blood in short time. That's why we must quickly stop bleeding. So this is temporary hemostasis. So this is not the treatment of the patient. It is impossible in the field, but we must just stop the bleeding and prevent blood loss. So it is in many situations quite easy. You can use just digital pressure to stop bleeding, but you must know areas when artery is located over the bone, and you must compress artery with your finger against bone. In such case, you can compress the artery successfully and stop bleeding. For example, this is the medial bicipital groove, or sulcus bicipitalis medialis, the location of the brachial artery, medial to the biceps. In this area, you can compress the brachial artery against brachial bone. Or you can compress brachial artery against the head of the humerus bone. Of course, everybody knows the location of the ulnar and radial arteries. And in case of bleeding from the palm, you can obstruct radial and ulnar arteries, and this would stop any bleeding from the palm. It is possible to obstruct the femoral artery and compress this artery against the pubic bone. Also, arteria dorsalis pedis is located over the metatarsal joint, and you can easily compress this artery and stop bleeding from the foot or toe. Temporal artery, you can find this artery easily by pulsation in front of your ear, and you can compress with finger to stop the bleeding for corresponding half of the scalp. Also, facial artery, you can detect facial artery near the angle of the mandible and compress it to stop bleeding from the facial area. You can also compress the carotid artery against the transversal branch of the seventh vertebra. These are points you must know to effectively stop bleeding by digital pressure and save life of the patient. Also, you can use tourniquet. You can apply tourniquet on the limb. This is the application of the tourniquet. But if you will not apply the tourniquet properly, it will increase the blood loss. And that's why. So we have arteries and veins in arm, isn't it? And if you apply the tourniquet too loose, then it will obstruct veins only, which are thin-walled and easily compressible. But arteries will not be compressed. So artery brings the blood to the limb, and this blood cannot get back because veins are obstructed by the tourniquet. That's why amount of blood loss will be increased. So you must apply the tourniquet tight enough to compress artery. Okay? How to do that? First, remember that you must apply tourniquet over the tissue, for example, over the patient's own clothes. It prevents or decreases the damage of tissues. After, you must check the pulse distally to the tourniquet, for example, radial artery pulse, and gradually squeeze the tourniquet. And the tourniquet must be tight enough to stop arterial pulse. So that means you obstructed the artery. If you tighten the tourniquet more, you will just damage tissues. More tight application of tourniquet is not necessary. So first, place the cloth under the clothes or tissue under the tourniquet, then check the pulse peripherally, if it is leg on the arteria dorsalis pedis, if it is arm, then radial artery, and tighten the tourniquet enough to stop pulse and not more. And it's necessary to attach small piece of paper with exact time of the tourniquet application, because when the patient will be transferred to the hospital, the surgeons must know when the tourniquet was applied, and if there is a danger danger of gangrene development. The same principle is true for the application of the tourniquet on the leg. Again, you must check the pulse, use the tissue under the tourniquet, and tighten the tourniquet enough to stop the pulse peripherally to the tourniquet. Also, bleeding can be stopped by the kinking of the artery, by maximal flexion of the limb, like this. You can use ordinary belt for that. And is it possible to apply tourniquet on the neck?
That's too dangerous. Translation.
Yes, okay. This is how to apply the tourniquet on the neck. Of course, it is quite difficult, and tourniquet must not obstruct the airways or the both carotid arteries, but technically it is possible, like this. And after the transfer of the patient to the hospital or to the medical center, maybe surgeon's office or primary care office, maybe, definite hemostasis is necessary. So the patient cannot be with tourniquet all the time, or you cannot stay at the patient with your finger compressing the artery, isn't it? So the bleeding artery must be found and ligated if it is not essential blood vessel. Of course, it is if this vessel is the brachial artery or femoral artery, and then ligation of the vessel can lead to the limb gangrene. That's why the vessel must be repaired. So vascular surgery is necessary. It can be just repair of the arterial wall with the sutures, or resection of the damaged part of the artery and reanastomosis, or even usage of the artificial vessel instead of the damaged artery. Local hemostasis is used during surgery. Yes?
In relation to the arm, what is the maximum amount of time the tourniquet should stay on? Because obviously,
you for the application of the tourniquet.
yeah.
Okay, it depends on the conditions. If it's hot, I mean during summer, the time is short. It's about 2 hours, but during winter, if the patient is exposed to the low temperature, the time can be up to 3 hours.
Okay, thanks.
You're welcome. Electrocautery is used to stop the bleeding during surgery. It's a surgical generator, so-called electrocautery machine. It has 2 electrodes, passive and active, and the same current flows through both electrodes and through the body of the patient. But passive electrode is wide, and this current is distributed to the large area, while active electrode has a tip, small tip. That's why this electricity is concentrated in one small area. That's why it takes effect, while passive electrode does not damage any tissue. There are also, this is monopolar cautery. And also bipolar cautery is possible when both electrodes are connected to the branches of the instrument, and current passes through the tissues between forceps. Also, there are advanced bipolar equipment like ligature, which seals the tissues and has a perfect hemostasis. It can even seal artery up to 6 millimeter diameter. It is amazing advancement of the surgical equipment. Laser also is used in modern operating theater. Also, argon beam coagulator. Argon is an inert gas which has a unique ability to transmit electricity. So imagine gas which transmits electricity. So argon is used to deliver the same electrical current to the tissues, and it leads to the excellent coagulation. Also, CUSA is the cavitron ultrasonic suction aspirator. Its device is used to cut liver or in brain surgery. Harmonic scalpel uses the ultrasound, ultrasonic waves, ultrasonic frequency to coagulate tissues. And CUSA is combination of the electrocautery and harmonic scalpel, actually, because it uses both energy, electrical energy and ultrasonic waves or high frequency friction. Topical hemostatic agents are applied on the bleeding area. This could be oxidized cellulose, gelatin sponge, microfiber, collagen, also biodegradable matrix, also bovine thrombin, so-called co-seal, flow seal. These are substances, actually thrombin glue, thrombin gelatin complex, which are derived from the bovine body, blood, and they are used as stimulators of the patient's own coagulation system during surgery. Fibrin sealants, bioglue, they are used in modern surgery. It is possible even to make some surgical interventions without usage of the sutures. Instead of sutures, during minor surgical interventions, it is possible to use a bioglue. It attaches the tissues with each other, also stops bleeding. Everybody knows Karl Landsteiner, which made excellent discovery and was the great scientist which discovered the blood groups A, B, and O groups, and also rhesus group was described later by Levine and Rufus Stetson, and blood transfusion got possible after these discoveries, saved blood transfusion. But nowadays, we don't use the whole blood for transfusion. We just use blood components. Okay, about this later. So there are 4 groups of the blood, O, A, B, and AB, and also rhesus groups, Rh positive and Rh negative. And in order to transfuse the blood, so for blood transfusion, we need several tests. Okay, which tests are necessary? First of all, we must determine ABO group of the patient and also ABO group of the donor blood. RH rhesus group of the patient and RH group of the blood. Then we must make cross-matching between the donor's red blood cells and recipient's serum. After that, if the test is negative, we start transfusion with biological test. So we infuse small amount of blood, about 15 milliliters, and then stop transfusion and observe the patient. By the way, for blood and blood products, we use the word transfusion. For other medications, including saline, we use infusion. Transfusion for blood and blood components, and infusion for other medications. So if the first biological test is negative, the patient has no complaints after the first test, we initiate another test. So infuse another 15 milliliters of blood, and then third test. And if all three biological tests are positive, we can start blood transfusion. But because of high likelihood of the complications, blood transfusion is not used anymore. So only rarely, with rarely exceptions, but in modern medicine, we don't use blood transfusion. We just send the donor blood to the laboratory. They made red blood cell mass and plasma, separate them, and we use plasma separately, transfusion of the plasma, and transfusion of the red blood cells. Okay. All right. Let's finish for today. If you have any question, please. All right.
During transfusion, right? If a patient develop reaction in the
Yes.
during transfusion,
Yes.
because you said that what you do was that after you do the test,
I will explain this in the remnant part of my lecture next time. We have several slides to discuss, including the blood transfusion complications. Okay, we will discuss it.
Okay.
Okay, then. See you next Tuesday. Goodbye. Good night.
Спасибо.
Good night, sir.